Welcome to the deep dive. Today, we're really getting into some essential knowledge, pulling key pharmacotherapeutic principles straight from your advanced practice source material.
Exactly.
We're focusing completely on those common ophthalmic disorders that, well, you as a primary care provider really need to have a handle on.
It's so crucial. I mean, specialists, ophthalmologists, they manage the really complex eye conditions, sure.
Right.
But you're often the first point of contact for diagnosis, for that initial treatment plan.
Mm-hmm.
So our aim today is to give you a clear, kind of step-by-step pharmacologic roadmap for 4 key areas. We're talking external eyelid inflammation,
Blepharitis, yeah.
acute infections of the surface like conjunctivitis, chronic dry eye, and then the big one, the long-term management of primary open-angle glaucoma, or POAG.
Exactly. So we're kind of moving from the outside in, right? Surface to interior.
That's the plan.
We've got quite a bit to cover, everything from basic hygiene up to some pretty specialized anti-inflammatory drugs. But the mission is clear. Cut through the textbook jargon and highlight those clinical pearls that you'll actually remember and use.
Let's dive in.
Okay, starting with the eyelids then. Blepharitis. Fundamentally, it's inflammation right there at the lid margin. And the sources really stress that treating it well depends on figuring out which subtype you're looking at.
Yeah, you almost have to play detective,
Yeah.
based on the gunk you actually see on the eyelid.
Okay.
So if you see eyelids that look matted, maybe a bit scaly, and the patient mentions losing eyelashes or they're growing in weird directions, that points pretty strongly towards staphylococcal blepharitis. That's your bacterial infection type.
Got it. Staph. What if it looks different?
Well, if the deposits look more oily, kind of greasy, and maybe the patient mentions issues like scalp dandruff or dermatitis elsewhere,
Ah, okay.
then you're likely dealing with seborrheic blepharitis that's more tied to skin conditions.
Makes sense.
And-
And the third word.
And the third one, which is really common, is meibomian gland dysfunction, MGD.
All right, MGD.
Here, you're looking for fatty, maybe even foamy deposits.
Yeah.
And often these patients might frequently get chalasia, those painless, firm
Yeah.
little lumps on the eyelid.
Yeah.
That tells you it's a problem with the oil glands in the eyelid margin itself.
So differentiating those is key, but what's the absolute first step, like before even thinking about prescriptions?
This is non-negotiable, really. Doesn't matter the subtype. Treatment always starts with strict eyelid hygiene and warm compresses.
Always.
Always. It has to be the first line. And a crucial counseling point here is that blepharitis is usually chronic. It comes back. Hygiene routine, the warm compresses.
Yeah.
It's often something they need to stick with, sometimes for life.
Okay, so hygiene first. But if we do confirm it's staphylococcal blepharitis, then we need to kill the bacteria. What are the first-line drugs?
For staph blepharitis, the goal is pathogen eradication. So we turn to topical antibiotics that work against staph. The chapter points to bacitracin ointment, or erythromycin, 0.5% ophthalmic ointment.
Ointments applied where exactly?
Right under the eyelid margins, usually once, maybe twice a day.
Okay. And you mentioned ointments. Is there a downside?
There is, and it's important for adherence. Ointments are great because they stay put longer, but they cause significantly more blurred vision than solutions do.
Ah, right. Need to warn patients.
Absolutely. You have to prepare them for that temporary blurriness. Otherwise, they might just stop using it.
Good point. And when do we say, okay, this isn't working, time for a specialist?
If you start this treatment, and after several weeks, the symptoms are actually getting worse, especially if you're worried about the cornea being involved or there's any vision loss that's your trigger.
Don't wait.
No. Immediate referral to ophthalmology at that point.
Right.
Second-line therapy is their domain. Okay, let's shift focus a bit. Move from the lid margin to the external surface itself. Conjunctivitis, probably the most common cause of a red eye you'll see.
The classic pink eye.
Exactly. And the key to managing it effectively is really about triaging based on the discharge.
The discharge tells the whole story, doesn't it?
Pretty much. So if the patient describes this profuse, watery discharge, often starts in one eye, then boom, quickly spreads to the other.
Yep.
You should immediately suspect viral conjunctivitis, usually adenovirus, and it's highly contagious.
Super contagious. Okay, what about bacterial?
Bacterial is different. Think thick, purulent discharge. That real gunky stuff that literally glues the eyelid shut, especially when they wake up.
Yeah. More common in kids, right?
Often more common in children, yes. That points strongly to bacterial. But then there's the third type, allergic. And the absolute hallmark sign for allergic conjunctivitis isn't really the discharge type, it's the itching. Intense itching. If the patient says, my eyes are so itchy, I want to scratch them out, think allergic.
Okay, so viral is watery, bacterial is purulent, allergic is itchy. Got it. Now, if we diagnose standard bacterial conjunctivitis, say, from Staph aureus or H. flu, what's the treatment?
For those common bacterial pathogens, you're usually looking at a 5 to 7 day course of topical antibiotics.
Like what?
Typically, erythromycin ointment or polymyxin B trimethoprim solution.
Ointment versus solution again.
Right. And the choice often boils down to patient preference, like we talked about with blepharitis, balancing efficacy with the visual blurring from ointments.
And if those don't work?
If first line fails, or if you need broader coverage, then you'd consider an ophthalmic fluoroquinolone, maybe like moxifloxacin. Some have better gram-positive coverage.
Okay. But we need to talk about the urgent cases, right? Not all conjunctivitis is just treated with drops.
Absolutely critical distinction. If your patient history or the clinical picture makes you suspect conjunctivitis caused by Neisseria gonorrhea or Chlamydia trachomatis,
Okay.
topical treatment alone is not enough. These are systemic infections manifesting in the eye.
So what do we do?
Immediate systemic therapy. For suspected gonococcal conjunctivitis, it's typically an injection of ceftriaxone plus oral azithromycin. For chlamydial, it's oral azithromycin or doxycycline.
And just to be clear, topical drops for chlamydia.
Pointless. Topical therapy doesn't work for chlamydial conjunctivitis. And critically, for these sexually transmitted causes, you must ensure partner treatment as well.
Huge point. Okay, switching gears slightly back to allergic conjunctivitis. Beyond telling people to avoid allergens and use cool compresses, what are the drug options?
We usually start with topical antihistamines. Things like alcaftidine or imidazine can provide relief.
And if that's not enough, for more persistent symptoms?
Then the combination agents are often more effective.
Yeah.
Drugs like olopatadine, ketotifen, azelastine.
Why are they better?
Because they do two things. They have antihistamine properties for that immediate itch relief, and they act as mast cell stabilizers to provide longer-term suppression of the allergic response, sort of tackling it from both ends.
Makes sense. Now, what about those popular over-the-counter drops, the ones that get the red out, like nafazoline or tetrahydrozoline?
Ah, the vasoconstrictors, yes. Big warning needed here.
Okay, what's the danger?
They work quickly to reduce redness, which patients like, but their use must be strictly limited. We're talking a maximum of 72 hours.
Why only 72 hours?
Because of the risk of rebound congestion. The moment the drug wears off, the blood vessels can dilate even more, making the eyes redder than before. It creates this vicious cycle of dependency.
Okay, so short-term use only. Any other warnings?
Yes, a major one. They are absolutely contraindicated in anyone with narrow-angle glaucoma.
Why is that?
Because constricting those vessels can potentially trigger an acute angle closure crisis, which is an ophthalmic emergency. So definite contraindication there.
All right, let's move into chronic territory with dry eye disease, or DED. This is, it feels like everyone complains about dry eyes sometimes. It's really common.
It is ubiquitous, and it's more complex than just not enough tears. It's really a disruption of the entire tear film structure.
The tear film, right. It has layers.
Exactly.
Yeah.
You need to think about those three layers to understand DED. It's like a sophisticated little sandwich on the eye surface.
Okay.
You've got the endomucous layer, which helps the tears stick to the eye surface. Then the middle thickest layer is the aqueous layer. That's your water, nutrients, moisture. And then the outer lipid layer, the oily layer, made by those meibomian glands we talked about earlier.
Yeah.
Its job is to prevent the watery aqueous layer from evaporating too quickly.
So if any of those layers are off.
Exactly. If there's a breakdown in any part of that system, not enough water, poor oil quality, bad adherence, it leads to instability, faster evaporation, and ultimately inflammation on the ocular surface.
Yeah.
That inflammation is key in DED.
Okay. So before we even talk DED drugs, what else should we be thinking about? Environment, other meds.
Both are critical. Non-pharmacologic first. Environmental controls, like using humidifiers, avoiding direct drafts from fans or AC, taking scheduled breaks during prolonged screen time. Simple stuff, but it helps.
Right. And systemic meds.
Yes. Super important to review the patient's full medication list. There are many common systemic drugs that can actually worsen or cause dry eye.
Like what? What are the big offenders?
Think antihistamines, diuretics, a lot of antidepressants, and even systemic beta blockers. These can all reduce tear production or disrupt the tear film.
Good to know. Okay, so we've addressed environment, reviewed meds. Now, for treating DED itself, what's the first step pharmacologically for mild or moderate cases?
The first line is typically artificial tears and lubricants, just supplementing the tear volume.
Seems simple enough. Any catches?
The big one is preservatives. Many artificial tears contain preservatives to prevent bacterial growth in the bottle, which is fine for occasional use. But if your patient finds they need to use artificial tears more than 4 times a day, that continuous exposure to preservatives can actually irritate the ocular surface and worsen things.
Ah, so frequent users need something different.
Yes. If they're using drops more than 4 times daily, they must switch to preservative-free formulations. They usually come in single-use vials. More expensive, maybe, but necessary.
Got it. Preservative-free for frequent use. What if artificial tears aren't cutting it for moderate to severe DED?
If palliative measures like artificial tears aren't enough, it usually means there's significant underlying inflammation that needs to be addressed directly. That's where the advanced anti-inflammatory agents come in.
Okay, the prescription stuff. What are the main options?
2 key players highlighted in the chapter. First is topical cyclosporin, typically the 0.05% emulsion.
Cyclosporine, how does that work? It's an immunosuppressant, right?
It is. But topically, it works by preventing T-cell activation and the release of inflammatory cytokines on the eye surface. By calming down that immune response, it helps break the cycle of inflammation and can actually increase the eye's own natural aqueous tear production over time.
How's it dosed?
Usually twice daily. And patients need to know it takes time to work weeks to months to see the full benefit.
Okay, so cyclosporine calms T cells. What's the other main anti-inflammatory?
The other one is Blepharitis, a 5% solution. This one has a different mechanism. It's an LFA1 antagonist.
LFA1 antagonist. What does that mean?
Think of LFA1 as a kind of docking molecule on T cells that allows them to stick to other cells, like those on the eye surface, promoting inflammation. Blepharitis basically blocks that docking process.
So it stops the inflammatory cells from interacting properly.
Exactly. It inhibits that key cell-to-cell interaction, directly reducing T-cell-mediated inflammation that drives DED. Blepharitis is typically dosed every 12 hours.
It's interesting. 2 different ways to tackle the inflammation. What about patients with Sjogren's syndrome? They often have severe dry eye and dry mouth.
Right. For Sjogren's, oral cholinergic agonists like pilocarpine or cevimeline can be used. They stimulate secretions generally.
Do they help the eyes much?
The source notes they tend to be significantly more effective for the dry mouth symptoms than the dry eye symptoms, and they can have systemic side effects like sweating, flushing, which can limit their use.
Okay. One last category for DED, corticosteroids.
Steroids. Yes, they are used, but with extreme caution. Topical steroids are fantastic for rapidly knocking down severe inflammation and providing quick relief.
But there's a catch.
A big catch. They're strictly reserved for short-term use. Think maybe a 2-week pulse therapy at most.
Why so short?
Because long-term use of topical steroids on the eye carries significant risks. Increased susceptibility to infection, cataract formation, and, ironically, inducing secondary glaucoma by raising intraocular pressure. So short bursts only, under close monitoring.
Okay, let's move to our final major topic. Primary Open-Angle Glaucoma, POAG. This is a huge one, right? A leading cause of irreversible blindness.
Absolutely. It's the most common type of glaucoma, accounting for maybe 80% of cases. And the damage it causes to the optic nerve is permanent.
So what's actually going wrong in POAG?
It's fundamentally a plumbing problem in the eye. Glaucoma damage is often linked to increased intraocular pressure, or IOP.
Right, eye pressure.
In POAG, the eye's natural drainage system, called the trabecular meshwork, undergoes degenerative changes. It becomes less efficient at draining the aqueous humor, the fluid, inside the front part of the eye.
So the fluid builds up.
Exactly. If the fluid can't drain out properly, the pressure inside the eye increases, and that sustained high pressure damages the delicate optic nerve fibers over time, leading to vision loss.
Okay, so the goal of treatment is pretty clear then.
Very clear and very mechanical.
Yeah.
Lower the IOP. The chapter emphasizes the need for an aggressive initial target, aiming to reduce the IOP by 20% to 30% below the patient's baseline pressure.
20 to 30% reduction. Got it. What's the first-line drug class we usually reach for?
For most patients, the first choice is one of the prostaglandin analogs.
Like latanoprost.
Latanoprost is the classic example, yes.
Yeah.
But also bimatoprost, travoprost, tafluprost. They're often first-line because they're very effective, generally safe, relatively affordable now, and the dosing is convenient, usually just once daily, typically at bedtime.
Once a day is nice. How do they actually lower the pressure? Do they fix the broken drain?
Interestingly, no. They don't primarily work on that main drainage system, the trabecular meshwork. Instead, they enhance fluid outflow through a secondary pathway called the uveoscleral outflow pathway.
So they kind of open up an alternate drain.
That's a good way to think about it. They increase drainage through this alternate route, which lowers the overall pressure.
Clever. Are there significant side effects we need to counsel patients about?
Yes, and one is particularly important because it's permanent. Prostaglandin analogs can cause irreversible changes in iris color.
Change eye color. Really?
Yes, especially in people with mixed color irises, like green-brown or blue-brown eyes. The brown pigment can increase, making the iris permanently darker.
Wow. Okay. Definitely need to mention that. Anything else?
They can also cause darkening of the eyelid skin around the eye and changes to the eyelashes, making them longer, thicker, and darker. Some of these effects might reverse if the drug is stopped, but the iris color change is usually permanent.
Okay, so prostaglandins first line. What if they aren't enough, or the patient can't tolerate them? What's often the next step?
The next major class we often turn to, either as an add-on or an alternative, is the topical beta blockers, like timolol.
Beta blockers. How do they work in the eye?
They work differently. Instead of increasing outflow, beta blockers decrease the production of aqueous humor by the ciliary body inside the eye. They typically lower IOP by about 20–25%.
Okay, decreased production. Sounds effective. But beta blockers, don't they have systemic effects, even as eye drops?
They absolutely do, and this is a huge safety consideration, especially for advanced practice nurses who are managing the whole patient. These eye drops are absorbed systemically.
What are the risks?
Non-selective beta blockers, like timolol, can cause bradycardia, worsen heart block, and critically cause bronchospasm. So they are contraindicated in patients with asthma or severe COPD.
Whoa. So an eye drop could trigger an asthma attack?
Potentially, yes. There's a cardioselective option, pataxolol, which has less risk of respiratory effects, but it's maybe slightly less effective at lowering IOP, and it still carries risks for cardiovascular side effects like slowing the heart rate. You have to screen patients carefully.
Definitely. Are there newer options available now, maybe things that work differently or combine mechanisms?
Yes, there are newer agents. One interesting one the chapter mentions is latanoprostene bunode. It's a prostaglandin analog like latanoprost, but it's also designed to donate nitric oxide within the eye.
Nitric oxide, what does that do?
Nitric oxide actually helps relax the trabecular meshwork tissue, that main drainage system that's faulty in POH.
Ah, so it tackles both pathways.
Exactly. It enhances outflow via the uveoscleral pathway like other prostaglandins, and it helps improve outflow through the primary trabecular meshwork pathway via the nitric oxide. This dual mechanism often leads to greater IOP lowering than latanoprost alone.
Very cool. And combination drops, are they useful?
Combination products are definitely beneficial, mainly for simplifying the regimen. If a patient needs 2 different types of drugs, combining them into one bottle, like a dorzolamide timolol combo, reduces the number of drops they have to instill each day, which can really help with adherence.
Makes sense. Fewer drops, less confusion. So just to quickly recap the typical treatment ladder for POHE.
Generally, it often starts with a prostaglandin analog first line.
Okay.
If the target IOP isn't reached, you might switch to, or more commonly add, a topical beta blocker, assuming no contraindications. And if you still need more pressure lowering after that, the next step is often to add a third agent, perhaps a topical carbonic anhydrase inhibitor like dorzolamide, or an alpha adrenergic agonist like bromonidine. #outro.
Wow, okay. We really covered a lot of ground there, navigating the pharmacologic map for blepharitis, conjunctivitis, dry eye disease, and primary open-angle glaucoma. We hit the importance of diagnosis, differentiating those blepharitis subtypes, reading the discharge for conjunctivitis, and walked through that stepwise approach, starting with hygiene or artificial tears and moving up to the more advanced agents when needed.
And maybe the biggest practical takeaway, especially regarding infections, is remembering and communicating about contagiousness. Bacterial conjunctivitis is typically contagious for 24 to 48 hours after starting treatment. But viral can hang around and stay infectious for up to 2 weeks. That's crucial for preventing spread.
Yeah, good reminder.
And always tell patients with any acute eye infection or inflammation, stop wearing your contact lenses immediately until it's fully resolved.
Absolutely critical. Okay, so wrapping this up, what's the final thought here? What does this all mean for your practice?
Wow.
I think the fact that a first-line drug for glaucoma, something seemingly simple, like a topical prostaglandin eye drop, can cause permanent, irreversible cosmetic changes, like altering someone's eye color.
Yeah.
And that another standard eye drop, a beta blocker, can have potentially serious systemic cardiovascular or respiratory effects. It's a powerful reminder, isn't it?
It really is.
That even highly localized treatment in the eye demands we constantly balance those local benefits against potential systemic risks and permanent patient outcomes.
You can't separate the eye from the rest of the body.
Exactly. So here's something to think about. Given these potential permanent cosmetic side effects or serious systemic risks from common ophthalmic therapies, what specific assumption about just using topical eye drops might you need to reevaluate in your own practice? How will you proactively counsel patients about these less obvious but potentially significant long-term consequences? That's your deep dive homework for today.